Hello, my name is Sue Piggott and I am the Senior Dental Research Officer with the NHMRC funded research project titled Minimally Invasive Approach to Manage Early Childhood Caries in Aboriginal Preschoolers. And the paper I'm talking about today is a qualitative sub-study of this project. To give you some background information, the main aim of the project was to test a model of dental care to young Aboriginal children in remote communities using a minimally invasive approach. This treatment approach relied mainly on using hand instruments to prepare a tooth for a filling, so no dental drill was used and without the use of local anaesthetic, so no needles. Here you can see the type of filling that's done, and where the decay is more extensive, a steel cap or crown is placed to cover the whole tooth, again without using any dental drill or local anaesthetic. Our findings on the clinical outcomes of the core project have been published and reported elsewhere. Our qualitative study is titled Parents' Perceptions of Minimally Invasive Dental Treatment of Australian Aboriginal Preschool Children in Rural and Remote Communities. And I would like to acknowledge the co-authors listed here: Cheryl Carter, Helen Forrest, David Atkinson, Tamara McKean, Rob McPhee and Peter Arrow. This study reports on the views of the parents of children who received the minimally invasive treatment approach, and also from those parents of children who had care through their usual service provider. We interviewed parents from both groups to get their perceptions of the care that their children received, and the interviews were carried out by the study CI and our Aboriginal Research Officer using a semi-structured yarning approach, and they were done in settings that were most comfortable and convenient for participants. So this may have been on a veranda or outside under a shaded tree. The interviews were recorded, transcribed and then subjected to thematic analysis. The main themes that emerged were of accessible care, care received and community engagement. Firstly, in terms of accessible care, the strong theme that emerged was of dental services not readily accessible. Here, the parent talks of living remotely in a sparsely populated community where dental services are unavailable. Another parent also talks of the absence or non-existence of dental services in her local community. The minimally invasive treatment requires very little in the way of instruments and equipment, and with the use of portable equipment, a dental-specific room is not essential for its delivery. Providing dental services in a child care centre, as was done in this community, provides a familiar and a safe place for families and the young children. Similar places in community, which are easily accessible, put the attendees at ease and ensure cultural safety is maintained. Another identified theme was for the care received. Here, the mother recognises the child is placed at the centre of care and reflects on the concept of holistically treating the child, not just treating the tooth. The care and compassion shown toward the child is recognised and appreciated. When child-centred care is employed, the parents can see their children are placed at ease. So when they see their children are relaxed, they also expressed feeling at ease themselves. The parent here from a test community talks of the rapport and trust created between the clinician and the child. The less invasive approach to treatment, without the use of the dental drill and the local anaesthetic, was readily accepted by parents, especially when they recognised their children held fears and anxieties around dental treatments. Through the use of this approach, the parent is grateful comprehensive or complete care can be carried out. Finally, the community and individual engagement was recognised as part and parcel of the tested approach. The parent here from the control group valued the provision of timely and detailed information around dental provider visits and spoke of how the engagement involved others in the community who readily relayed the information, thus enabling the seeking of care. Engagement at the individual level is pivotal in how the care is perceived. Here, the feeling of trust and collaboration is reinforced when treatment information and regimes are given in easily understood lay terms. and where engagement was absent, it can have a significant impact. This mother from a test community spoke of feeling shamed and of a reluctance to return for further care. We found using the minimally invasive approach enabled the delivery of accessible dental services to children in remote communities. The use of minimal instrumentation and portable gear reduced the need for high-tech equipment and allowed the treatment to be delivered in non-traditional settings and in community. The comment from this parent indicates the desire for services to be delivered locally. The findings from this study and the companion papers suggest that a minimally invasive treatment approach was feasible to deliver, it was acceptable to those receiving the care, and clinically successful. The underpinnings of this tested approach are services that are accessible in community, strong community and individual engagement, and treatments delivered in a child-centred manner. We believe the minimally invasive approach has a great deal of merit and should be considered when services for the remote communities are planned. Thank you for your interest in our paper.